speaker today, Dr Louise Winteringham. Louise is head of the Translational Cancer Program at the Harry Perkins Institute of Medical Research, and she's program manager of the Liver Cancer Collaborative there. So Louise is a cancer biologist. She's indicated to me just before that she considers herself quite new to biobanking, which is a good thing, I think. She has more than 25 years experience in molecular biochemistry and gene regulation. She established and heads the Perkins Cancer Biobank, and she works with a multidisciplinary team to facilitate collection and analysis of tumour samples. She's also coordinating a customised secure digital environment to integrate research data with patient information for precision medicine in oncology. And she's also successfully established immune-compromised mice using CD3/4 cells from cord blood to investigate immunotherapy drug responses in combination with novel treatments. And she also oversees the production of PDX models from several different cancer types. So Louise is also director of the NCRIS Phenomics Australia Perkins node, and this capability is developing non-animal technology that will focus on organoid developments and drug screening, I guess, to increase possibilities of research that might not involve animal models. And she has been a member of the Phenomics Australia Scientific Leadership Committee since 2013. So Louise today is going to be talking to us about, her title will be Biobanking, Are We There Yet? And she's going to be talking about biobanking in WA, challenges and opportunities in terms of developing a statewide biobanking initiative, and talking about the Perkins Cancer Biobank in more detail. So thank you very much, Louise. Really looking forward to hearing your talk and looking forward to some great discussion afterwards. Thanks.
Thanks, Jenny. Thanks for that lovely introduction, and thank you very much for asking me and inviting me to give this talk. So I pose this question because I really believe that biobanking has an amazing opportunity to be involved in a lot more research and medical health, other than providing an amazing resource. I really think that biobanking can facilitate translation and precision medicine, and I'm going to talk about this in some detail later on. So Jenny has given me a wonderful introduction, and so I'll just quickly, I just wanted to make sure that you understood where my roles interact, and I have three main roles, and they're all really around biobanking and collecting and working with samples that we collect. So at Perkins, I head the Translational Cancer Research Program, and as part of that program, we have developed humanized mice that have a human immune system, so we can look at testing immunodrugs. I also have established the Perkins Cancer Biobank there and continue to oversee the operational activities of the biobank, specifically the ethics and governance. And we just recently set up a laboratory management system, Open Specimen, which I'm sure many of you use as well. So the Liver Cancer Collaborative, which I will talk about briefly as well, is a very large project looking at liver cancer, and a big part of that is setting up a liver cancer biorepository. So the biobank was tasked with doing that. And Phenomics Australia, have recently set up an in vitro service, and we are lucky enough to be part of that. And because we have access to tumour tissue, we have the capacity to then make these into organoids, which can then go back into the biobank and be accessed by other people. So just a quick outline of what I'm going to talk about today. So I'll talk about biobanking in WA. So WA has an incredibly rich biobanking history, and I'm just going to briefly mention three very significant collections: the Busselton study, the RAIN study, and the Joondalup study, and then talk a bit about what WA is doing to prepare itself for statewide biobanking. I'll talk a bit about the Perkins Biobank and our broad approach to biobanking, and then look forward a little bit to see maybe what the role that biobanks can play in leading translational research. So this is the first of one of the very large cohorts that WA have, and this is the Busselton study. And It was set up in 1966. Now, I think I find it quite amazing that Western Australia has these 3 very large cohorts, and I think it's a big part of it is probably due to its geographical isolation. But the Busselton study was set up in a small town, which is about 200 kilometres south of Perth. A small town. At the time, it had about 6,000 people living there. And this was set up by a local GP, Kevin Cullen. You might recognise his name. He also set up a very famous winery in the same region, pretty much at the same time. But this test, you can see this cohort started collecting samples in 1966. And their goal was to do broad testing of blood markers and to collect detailed questionnaires about the population's health. Now, Dr. Cullen was very keen that these results would be provided back to the participants, and they would, but indicating anything that was outside the normal range that could be flagged with their GP. There was a lot of controversy about this at that time. You can imagine in 1966, all of his colleagues thought that this would create an incredible amount of panic and people and chaos. But however, it worked really well, and GPs were able to address any issues that individuals had. And one of the key findings from doing this study was that for every known patient that had a disease such as hypertension or diabetes, there was another who didn't have the symptoms yet but had the condition. So they were able to start preventative medicine such as changing diets, increasing exercise and things like that, lifestyle changes that would would prevent the onset of these diseases. So over this time, there have been several new focused studies, and there have been numerous collaborative scientific publications. So this is still ongoing, and it's sort of had a bit of a rebirth in the last few years, and new studies have been undertaken. So the second one that I'm going to talk about is the RAIN study, and this is led by Professor John Newnham, AO, and this was established in 1989, and his focus was really on understanding pregnancy and preterm birth. And this study followed mothers and children from pregnancy through childhood, adolescence, and adulthood. And it has over the time become a multi-generational study. So Gen 2, the mothers were Gen 1, and they were studied in early pregnancy. The children that were born to these mothers became Generation 2. The grandparents of these children became Gen 0, and Gen 2 are now having their own children, so we now have a third generation. So it's become a multi-generational cohort study. And again, there was a lot of questionnaires, there was a clinical assessment, and the follow-ups of Gen 2, you can see, were fairly frequent. And they have done some genomic analysis, but not too much. There's a couple of GWAS studies, and again, over 600 peer-reviewed publications. So a very productive study. So the final cohort study I'm just going to mention is the Origins project, and this is a very recent study, and this is being undertaken at Joondalup Health Campus and Telethon Kids Institute. And the goal of this is to focus on improving child and adult health. And they're following 10,000 children and their families. So you can see that there are currently 7,000 birthing women, around 8,000 babies, and also non-birthing partners. And the goal of this is to uncover the causes and chronic conditions such as asthma, eczema, obesity, and mental health. So this is progressing really well. They've distributed more than 7,000 samples across 11 projects, and they are again making major inroads in understanding health. And so the WA statewide biobank. So we In 2018, stakeholders were invited to a consultation that established a biobanking committee. So that was really the beginning of WA thinking about and trying to plan for a statewide biobank. From that first consultation, there were two main outcomes. One was that we should establish a registry of biobanks to try and capture what was already in place, and then develop a biobanking strategy for WA that considered things like how to integrate the current operating biobanks, how to maintain this very rich historical collections, how to facilitate the inclusion of new biobanks, and could we harmonise ethics and governance, and did we want a single facility or would we stay with a network? So these were all questions that had to be addressed, and that was which are very focused around funding, of course. So which was something that at that time we didn't really have. So we have managed to put together a biobanking model. It's still not clear whether this will be the final strategy, and it is definitely not clear how that will be funded. So, and we also have put together a registry of biobanks in Western Australia. So they sit on the WA Health Translation Network website, and we have at the moment currently 38 biobanks that have self-registered to have their biobanks included in this registry. So there's probably more around WA that haven't registered, and we continually try and update this so that we capture what is actually the current biobanking situation in WA. So the funding for biobanking is always a very difficult it's a very challenging thing to actually have to address. Quite often biobanks have money provided at the outset, but it is very hard to find sufficient funding to keep them sustainable. And there has to be a model that allows that to happen. So in WA, we're very lucky to have the WA Future Health Research and Innovation Fund. So this was established in 2012. It was created from a Futures Medical Research Foundation grant, and it didn't become available with the appropriate legislation until 2020. And this fund has been really instrumental in sort of starting to bring together and focus on biobanking at WA. So in 2021, they awarded 1.5 million across 16 biobanks to provide support to these small biobanks while a new state model was being developed. So I guess that suggests that they are really going to support a state biobanking model. And then just this year, they have provided significant funding to cohort studies. So I think it was just either this week or last week, they announced that they have provided $2 million across 7 cohorts to help with operational support. And the 3 cohorts that I talked about have been included in that. And they will also announce very shortly, I'm sure, a cohort studies research support program with grants up to $1 million for over 3.5 years. So there is some support starting, and I guess the goal at the moment for the state government is to make sure that these biobanks are able to continue, that we don't lose very valuable samples and information, but that there is a strategy to bring them together and to maintain them into the future. So we are really poised to be part of an Australian-wide biobanking discussion. So I'm going to move a little bit onto where I think biobanks should be in research. And I went into research because I really do have a passion to try and find better outcomes for people that have cancer. And this is still, now that I've moved into biobanking, this is still a passion that I have, and it's what drives my work from day to day. So I think one of the things that's really amazed me over my career has been the development of big data. So I remember probably doing one of the very first PCR reactions that happened in WA with water baths. So we would take samples from water baths were set at different temperatures, and you would move them when the timer went off. And, you know, so we've gone from being able to look at the transcription of a single gene, one gene at a time, to being putting it all into one reaction and being able to look at the transcription of the entire genome. And then along with that comes the collection of all of this data. Being in a position to start collating that data and reusing it is really exciting. So the other reason that I think this is really important is that for us to really develop precision medicine, we need to have both clinical data and research data coming together. So the clinical data is really critical to provide the context that the research data will sit in so that we can get precision. And there needs to be a way of collating all of these data into an environment that can be accessible, but really can be where people can analyze their data so that we can drive new discoveries and we can develop precision medicine to inform clinical decisions. So when we started thinking about Perkins Cancer Biobank, this was all in the back of my mind. So in January 2017, which is really not that long ago, we were having a strategy meeting, and the requirement to access patient samples to facilitate translational research was very prominent in everybody's minds. And so this was something that we decided as a group that we really wanted to do. So we decided that the easiest way, because we didn't have a lot of funding to put into it, so we decided that we would collect cancer samples prospectively, and this would be informed mainly by funding availability. So as someone, researcher got a grant, they would build into their budget the collection of samples, and we would be able to collect prospectively. And the other thing that came up was that there were multiple research requirements. So everybody wanted, all the researchers had different assays that they wanted to undertake with these samples. So I was tasked with this, with making a biobank that had a broad enough ethics approval that we could collect any cancer that we needed when we had the funding available, and that we could do any we could do what we needed to achieve the research outcomes without having to continually go back to get further ethical approval. So to tackle this, in June 2017, we established a community reference group, and we presented our proposed biobank to the community members. So I guess it was quite unique in that it had such a broad overreach of not only cancer types, but also research activity. And they were very excited about it. They provided feedback. They thought it was actually a no-brainer. They thought that was a really good way to do it. It saved a lot of time. It meant that individual researchers were not spending a lot of time writing research ethics proposals. And so then in June 2018, we submitted our ethics to our local ethics committee. I think it got returned to us once, and we made a few changes, and then it was granted in September 2018. But then it took nearly 2 more years to go through the governance process. This was an incredibly long process, and didn't help that COVID started, and there were other confounding issues as well. But we eventually, in July 2020, had governance at each of the hospitals and Path West, and we were able to start collecting samples. So this was our aspirational model for the Perkins Cancer Biobank. So we would have patient consent and sample collection, and this would be longitudinal over a patient's journey so that we could access samples across different treatments and outcomes, relapse, recurrence, etc. We also wanted to collect very detailed clinical data because we knew that for us to really develop precision medicine or really meaningful outcomes, we had to have that context of the clinical situation. We can store, we had to set up sample storage and management. So as I mentioned, we were lucky enough to get a small grant to put in, set up Open Specimen, and we now use that as our management, laboratory management system. And we also have some long-term storage, but most of our samples that come in get distributed immediately for data generation, or they are stored very briefly in the biobank prior to them being turned into DNA or RNA. And this, one of the really valuable points with being able to do this is that when you have assays like single-cell sequencing or organoid development, you can provide fresh tissue very easily and quickly just by organising people to collect the samples when they come out of the patient. So it became a really important part of the biobank that we were able to do this distribution to these researchers for this very broad range of data generation. So the data generation at the moment we're doing includes all of these things and probably other things, and some biochemistry as well that we're doing. And the part of being able of setting up this very broad overarching data generation within our ethics was that we would guarantee, or we would do the best that we could to make sure all of the data becomes publicly available. Now, this is something that when we set it up, we didn't really understand where we would go with it, but because of our liver cancer grant, we've been able to really develop this data capture to a much greater degree than we thought we ever would be able to. And I'll talk a little bit more about that in a little while. So this is where the Perkins Cancer Biobank sits at the moment. We have a lot of liver participants. So these are the number of participants that we have enrolled. So we have nearly 230 liver cancer participants, and this is by far our largest part of our biobank because of our liver cancer program. We have a lot of melanoma samples, and then we have other researchers that are working on GIST and brain and head and neck, and we collect these samples as they become available. We set up collaborations with clinicians, and then we organise the collections as they are available at each of the 3 hospitals. So I mentioned our liver program, and this is where we're at with our liver program. So we have 229 participants, 130 of them have given us liver biopsies, and 204 have provided blood samples, and we have 32 resections. So the liver cancer program was a very ambitious project that came together in 2020 and was provided as a grant to the Cancer Research Trust, which is a WA not-for-profit trust that provides very large funding for cancer research. So this was the plan for the liver cancer project, and I've taken this directly out of our application. So the goal was to collect. So one of the things with liver cancer is that it has a very abysmal 5-year survival rate. It's less than 20%. It's probably one of the few cancers that really never biopsied for diagnosis. So mostly diagnosis is done via imaging. So there was often not a lot of samples collected, particularly around early and intermediate stages, to be able to do any sort of real analysis, meaningful analysis on. So we have in Perth, we have an amazing group of hepatologists and interventional radiologists and surgeons, and they were really starting to drive the taking of biopsies to diagnose liver cancer. So we were able to, they were very keen to join in this program. And so now what we do is, well, our interventional radiologists, when they take a diagnostic biopsy, they will take biopsies for research as well. And so this has really allowed us to put together this incredible biorepository of liver cancer samples. So the goal was to collect the samples, to provide them to platform technologies such as omics, organoid growth, and PDX models for preclinical studies, to undertake as detailed bioinformatics as we could, to use this to address key research themes, but also to feed all of this data along with the clinical data into a state-of-the-art database for patient treatment and prediction outcomes. So it is was a very ambitious goal at the time when we submitted it in 2020. We were successful in receiving the grant. So the Cancer Research Trust grant was around 5 million, and then we had 5.8 million co-funding from various not-for-profits and organisations around WA. So this is where what we are actually doing with this now. So we are doing DNA, both DNA and RNA sequencing. So we're doing whole exome sequencing. We're doing a lot of single cell sequencing. We're about to start on long-read sequencing using a nanopore technology. We're making patient-derived organoids, and we're just starting to optimize growth of these liver tumors in PDX mice. So the goal is that all of these data will come together, and together with very detailed clinical data that we are currently collecting through our medical colleagues, will go into a database that will be able to be used to inform clinical decision making. So in terms of numbers, this is what we're at. So we have starting to do some CT DNA from plasma to look at a panel of probes to predict relapse and therapeutic stratification. We're about to start long-read nanopore sequencing across the whole range of samples. We've done around 85 RNA sequences, and we've just set up a pipeline in our digital environment, which I'll talk a little bit more about in a minute. We've done 101 whole exome sequences and looked at we have these ready for access by researchers. There's done 77 single cell sequences, and this is being undertaken by one of our researchers at Perkins Cancer. And we've grown 18 patient-derived organoids, and we're about to start our first drug screen using these, as well as one of the key issues with this is that Ben Dwyer, who's running this platform, has found that he is able to alter the matrix to get a much greater success rate than anybody else that is in growing these organoids. So this has been a focus of his over the last couple of years. So this panel on the right-hand side just shows all of the different participants and what we're doing with each of the samples. So our goal is really to get as many different pieces of data across each participant at each time point, so that we can really build some complex biomarkers that will predict treatment relapse or treatment resistance or recurrence. So the one thing that we have been really able to develop through this liver cancer program, mainly because we have the funding to do it, has been to think about how we deal with integrating very sensitive patient information with research data. So early on in the program, we partnered with a company called Iridia, and they have developed this secure digital environment. So their environment is made up of two main components, a FAIR component, where the metadata is discoverable, and where data can be requested, and workspaces where individual researchers can access and analyze the data, or they can bring their own data as well and integrate their data with data that's within this collection. So there is the workspaces are wholly owned and operated by individual researchers. They can let into their workspace whoever they want, so they can work on their own data without it being compromised. There is people that own the data can have metadata available that's searchable, but then the data they would need to the data is requested, and individual owners have authority to either approve the data transfer into a workspace or not. So you have these inbound airlock and from FAIR into the workspaces. And once the data is ready to be downloaded, again, there's an outbound airlock that allows you to remove the data out of this secure environment. And then as the data is generated in the workspace, it gets transferred into FAIR, so that you're continually building up the data that's in FAIR. So to be able to do this and to hold sensitive information, Iridia had to build a very secure and trusted environment. So they follow a number of security principles. So they have the Open Web Application Security Project best practices. They use a lot of coding controls and testing to ensure that the environment is secure. And they have an ISO accredited information and governance model. And the other really important thing about doing this and making this as a best practice is adopting a common data model. So we're working really hard on using OMOP within our data as we store it, so that it can be easily findable and accessible and mainly interoperable. So all of these data then drive a lot of research questions. So we have a whole heap of research questions that we're answering around liver cancer, including around tumour heterogeneity, new biomarkers and therapeutics, and new drugs through the organoid program. So this is sort of where I see our biobank sitting, and it's a model that I hope could be extended, because really it would function best if the model is if there are multiple of these models around the country and globally. So this digital environment, this secure digital environment, has to sort of sit in between the biobanks who are collecting all the data and for storage and distribution, but can also be data stewards, which is how we've set up the liver cancer program. So all of the data that is generated from the samples that we collect in the biobank is fed into this secure data environment. The hospitals have a really important part to play in this, because they provide all the clinical expertise and the clinical data and outcome information, and all of that has to also be in this digital environment, so that we can integrate all of the research data with all of the clinical data. And from doing this, I think that we can then feed back into the health system, precision medicine, information that would inform the clinical decision making, as well as things like patient stratification for clinical trials. So interestingly, this is where biobanking is headed in the UK, and this is something that I've become really excited about. I think it's an amazing opportunity for Australia to really develop its biobanking. strategy as well. And I guess this has come through our partnership with Iridia and being involved in using and customising this secure data environment. So NHS England have just set up this transformation directorate, which I must admit sounds like something out of 1984, but it's very new. And they have developed this data saves lives strategy, which commits to funding the implementation of secure data environments as the default way to access NHS health and social care data for research and analysis. So their goal is to have these secure data environments as the default way to access data. So this means we move away from a data sharing model where sensitive data was actually shared outside of a secure environment, even though it was de-identified, so that it could be integrated with research data. And so they're moving away from this data sharing to a data access model where data doesn't actually leave the environment. It means that individuals have much more control over their own research outcomes and data, but it also means that very sensitive data like patient information can be accessed and utilised and integrated with the research data, but remains very secure. And so they are committing to 11 subnational secure data environment teams that will collectively cover the whole of England, and they bring together all of the different players. Like they have integrated care boards and local universities, industry partners, and they're building on existing collaborations and research partnerships. So this is an amazing model, I think, and something that I really believe that where biobanks can be really integral in developing these and collaborating with hospitals to set these up. So there's also just recently announced a federated pan-European paediatric data network. And again, this is about federating multiple data and research sites across Europe so that the data can be shared and accessed by more people. And again, the important thing about this is that they are also adopting OMOP as a common data model approach. So we might be able to see Australia as existing like this, where we have these secure data networks with collaborations between biobanks and hospitals, where the data exists in these secure and trusted environments, and where a researcher who may need to access samples from multiple different hospitals can also easily access the patient information that goes with it. They can build their data sets because they have such broad access, and we can really push forward precision medicine and personalised medicine through this type of federated data network. And I guess the goal eventually will be that we can federate all of Australian networks with other global networks that exist as well. So that's my vision for what I think we should be aiming for. Very ambitious, but I think it's something that's doable. So finally, I'd just like to thank all of the Biobank team at Perkins. So we're very lucky to have 3 nurses that work with us, 1 at each of the hospitals, who are fantastic in coordinating all this collection of the samples. We have lab people. Larissa works is our Phenomics Australia scientist, and she is running the generation of the PDOs, apart from the liver PDOs, which Ben runs through the liver cancer program on his platform. And then there were the people that are involved with the liver cancer program, which is led by Peter Liebman and Nina Turnitz-Parker, and Michael Wallace, who is an amazing hepatologist based at Charlie's, which is where Perkins is here, who has really been instrumental in coordinating all of this surgical and clinical teams around the collections, and convincing them that taking biopsies in liver cancer is the way to go forward. And as well, the Liver Cancer Collaborative has more than 50 scientists and clinicians attached to it. So we have a wonderful partnership with each of the 3 teaching hospitals and our pathology provider. We have an incredible consumer community involvement program. A lot of the money to fund the Perkins Cancer Biobank has come through the Make It Cancer 200 ride for research, which had 1,800 riders just a couple of weeks ago for doing a 200-kilometre ride. And we have the Liver Cancer Collaborative has a number of partners, and I'd particularly like to mention Minderoo, who really have gone through this data journey with us, and sort of guided us in terms of the way forward with big data. So thank you very much for listening, and I'd be happy to take any questions.
Thanks, Louise. That was really interesting. Yeah, so if people have got questions, feel free to put up your hand. I'll probably call on you. And just maybe while we get started, I've got a couple. My first one, I guess, was around molecular subtyping in liver cancer. I don't know much about that. Whether there are different sort of recognised molecular subtypes that have got targets already. Could you comment on that and the degree to which your cohort sort of spans those molecular subtypes?
Yeah, look, it's very, there really isn't a lot of work that has been done, particularly early and intermediate, just because there's not been a lot of samples available. There are a number of mutations that are very consistent across liver cancer, despite across all the different etiologies. So we have, we've been there. One of the big issues with liver cancer is this increasing metabolic etiology, and this is based on lifestyle, and this is probably what's driving the huge increase in liver cancer globally. So it's a very new field in terms of understanding what the genetic makeup of this is, and how it changes across a patient's journey. So why they, liver is amazing, and you can resect a huge amount of the liver, and theoretically you're cured from liver cancer because the cancer's gone. But often it comes back still, even after resection. So there clearly is things happening in liver cells that occur very early on, and there is not a lot known about subtypes. It is definitely something that we're doing. So one of our students is looking at the difference, the heterogeneity across liver tumours and between tumours in the same patient. So we hope to be able to answer some of those questions. There just really hasn't been a lot of research done.
Yeah, that's kind of shocking in a way, isn't it? Given, that liver cancer is quite a common cancer, and outcomes haven't improved for some time. Yeah.
So the other thing that's really happened is that they have really they've really embraced immunotherapy for liver cancer. And again, doesn't work for everyone. In fact, I think it's probably still around 20%, but it doesn't necessarily increase the life expectancy very much. But it does provide, for some people, it works really well. And so again, one of the things we're doing is we're collecting blood samples across before treatment and then after each successive treatment, so that we can look at the changes that happen and what might be driving resistance or recurrence.
Thanks, Louise. I have another question from Carmel Quinn. And so Carmel's asking about patient consent, about the amount of information you're required to give participants about how their specimens and data will be used. And are you required to also communicate with them about any research results that have been generated, either using specimens or data?
Yep, both. So this was why we were very keen to have a very in-depth discussion with our community group, because we were very cognizant that we were asking a lot of people. And it was very interesting because they sort of didn't see it as a big issue at all. So we have both options. So normally a biobank will provide samples to other ethically approved projects through an MTA. So we can do that as well, and we do that in some instances. But we also, where we can provide an overview or some sort of governance across what's happening with the samples, we can generate these data. So it is all, and we developed the patient information and consent form with our community group so that it was very clear to them how we should discuss it with the participants, and so that they were aware that we were going to undertake these research activities with the samples. And we do provide, part of the patient consent form asks if they want to be emailed results or emailed about new discoveries and research outcomes, and we take that on board and we provide that back to patients when they have requested it. The liver cancer does have its own website, and data does go up on that as well. So yes, it is something that we were very cognizant of, and that we have a lot of governance around from our end.
Yeah, look, we've still got time. If people have got questions, feel free to just raise your hand or pop the question in the chat. But I'm kind of wanting to ask about what is OMOP, Louise? Am I sort of showing my ignorance here? I've not heard of it before.
It's an observational medical outcomes partnership, basically. So it's a group of people that have got together, and they have developed a protocol around what you call things, I guess. So when you're putting data into a database, anything from a blood test or any test is a measurement. So and when you're listing a diagnosis, it sort of needs to conform to a certain type of language. So it's about being able for data to be interoperable, I guess. So this is what they're trying. So you can find the data that you really want and that you're really interested in, because there is this common model around how things are labelled and organised and structured. So
it's a bit like an ontology,
Yeah,
something.
It is.
Oh, someone's put the page in the chat. Thank you.
Oh, good. Yeah, and it's an important part it's an important thing for us to start. It was really, we were very lucky because we are relatively new and we could start from the beginning doing this. It's difficult to do retrospectively, I think, because there's a lot of work involved. And I mean, even doing it prospectively, our clinicians, there's a little bit of a pushback because you ask them to refer to, or to be able to find things in a manner that might have a vocabulary that they're not used to. So there's sort of like, oh, what do you mean it's a measurement? It's not a measurement, it's this, or and so we sort of have gone halfway. And there are programs that allow you then, if you sort of set up the model correctly, even if the vocabulary is not completely compliant, you can then go through once you've got your database set up, and it can change that vocabulary to be more compliant.
Right. Yeah, no, it's interesting. I think that's often a challenge, isn't it? Sort of getting the language such that everyone knows that they're talking about the same thing.
Yeah, I think and if we really want to make the data interoperable, it does sort of need to be along those. We need to have some commonality in how we discuss how we label the data. Really.
Does anyone else have any other questions or comments? We've still got a bit more time. I mean, Louise, I know that there's a sort of a national data strategy being sort of worked on through NCRIS. Is what you're doing part of that?
Look, we've discussed this at Phenomics Australia, which is part of the NCRIS Health Group. And it is definitely something that we want to be part of and be part of the discussion. The discussion hasn't really started yet, other than very generally, but it is something that I would really like to, be part of. I really think that we have an opportunity, while the government is ready to talk about it, about how we approach what could be a national strategy, and how we encourage people to look at their biobanking and activity, and how it can make a contribution to things like precision medicine. I think that the whole focus on translation and precision medicine in the health space is really important, and it's really going to drive the way that patients are treated. But it's not really clear, I don't think, how we're going to get to that point. And I really think that biobanks can play a really important role in facilitating, that collaboration between researchers and hospitals to bring together the data that's required to really develop those types of things for like precision medicine.
Yeah, I think that's a very important message, that biobanks are at that sort of nexus between research and clinical care, and can play a big role. We have a couple of questions from James Kent here in Sydney. So he's asking, does OMOP include pathology data? And if so, how does it interact with the WHO IARC classification of tumours in terms of an international collaboration on cancer reporting?
Yeah, look, I think I don't know the specifics, but I know that there is a very active OMOP community, and I know that is definitely on their radar, and I'm sure that it is part of what they include in their guidelines. They do have some very descriptive guidelines about how you architect your database and your data so that it does conform to this. One of the really difficult things with classifying tumours, and I know particularly with liver cancer, is that depending on which jurisdiction you're in, or which country you're in, or even within the same country, they are diagnosed differently, so that they don't always have stage 1, 2, 3, and 4. And there are lots of different ways of looking at the classification of tumours. So I think it's very dynamic. OMOP is very dynamic. It's a very active community, and it's something that I think will be formed as we go. I guess as more people become used to using it and are wanting to employ it and include it in their own databases, it'll change, and it'll hopefully become more workable for people, and more inclusive of what's already there and what people are using.
Thanks, Louise. We've got one more question, I think. We've got time. So Umber here from the Biobank is asking about data sharing with researchers. Just how does it work, and do they need to acknowledge the biobank or make citations?
Yeah, so we have a publication strategy for researchers, and there's a paragraph on how to acknowledge the various contributors, including the biobank. So as the way that we're using the liver cancer program sort of as a pilot program for setting up this digital research environment. And the way that it's quite new, so we've only got really our first major set of data in there, which is the whole exome sequencing that is now available to all researchers. We've made that open to all researchers. So they get a login to the environment, they get their own workspace, and then they can search for the data that they want. They can request it, and we approve it. So there are managers that approve data transfer. Or if the data belonged to an individual researcher, they would be asked. They would get the email saying, this person wants to access these data that are yours. Do you approve it? And once you approve it, it just automatically gets moved into that person's workspace, so they have access to that data. So all the data stays within the environment. You can request to download the data. Most of what we're going to do will be to allow people to download summary data, but not whole data sets. All of the data can be worked on within the workspace, so the tooling is there. There's RStudio and Jupyter Notebooks and other tools that you might need to analyze the data, and you can add more in as needed. So the environment in the workspace is set up to do most analyses that would be required.
Thanks, Louise. We've certainly asked you lots of questions, and I think that reflects how interesting your talk was. We're very glad to have recorded this for anybody who had a few Optus-related issues today. But yeah, thanks so much for a really great talk. Really interesting. As always, I learned a lot, and yeah, we wish you all the best with the research, and we look forward to hearing more about it as the research unfolds.
Thanks, Jenny. I really appreciate it. It's been an absolute pleasure.
Thank you, Louise. Thank you.